They said to me, "You're too young to be having a heart attack."
The paramedics thought it was a panic attack, so they took me for a slow, quiet ride to the hospital.
My initial workup said I was fine, but I was in serious pain.
I was diagnosed with the flu and sent home.
Imagine at a time when every second counts. You feel unheard, unseen, and alone.
I knew something was wrong.
I was so confused and I was scared.
Cardiovascular disease is a woman's greatest health threat, yet women have been underrepresented in research and are often misdiagnosed.
My stroke was misdiagnosed as a migraine.
I later found out I was having a heart attack postpartum.
An ischemic stroke, preeclampsia, and HELP syndrome.
A SCAD heart attack.
It's time for us to use the power of our collective voice and fight for equal representation in research, treatment, and funding. Because together we are stronger against cardiovascular disease. When it comes to our unique health journeys, we have the world's best resource, each other. When we motivate each other, educate each other, and inspire each other, we have an unmatched ability to drive real change, to make sure all women are seen, heard, and counted.
Women like me.
And me. And me.
And me.
And me.
Let's support better health for all women. Let's ensure all women live longer, healthier, and happier lives. That is the power of the Go Red for Women movement. So let's all go red.
Together.
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 Good afternoon, everyone. On behalf of the Department of Veterans Affairs and the Office of Women's Health, thank you for joining us for today's Veteran Town Hall. The month of February is recognized as American Heart Month, a time when all people, especially women, are encouraged to focus on their cardiovascular health. My name is Dr. LaToya Harris, and I will serve as your moderator today. This town hall is one of many activities that the VA hosts in order to provide education and promote awareness of the impacts of cardiovascular disease. For many years, we have collaborated with the American Heart Association to ensure that veterans have access to the latest resources and research related to heart health. I am joined today by Heather Simpson and Haley McGannon from the American Heart Association. Heather, would you like to bring greetings from AHA?
Thank you, Toya. Yes, I just wanted to pop on and say thank you for joining us and give you a little bit more information about Go Red for Women. So Go Red for Women is the American Heart Association's signature movement dedicated to women's health. And we launched in 2004 as many women were unaware that cardiovascular disease was the #1 killer of women. For over 2 decades, we've sought to address awareness, clinical care gaps, and fund life-saving research, all to fight against this greatest health threat. But there's still more work to be done, which is why we're so proud of our alliance with the Department of Veterans Affairs to reach more women veterans like you. So on behalf of the Go Red for Women movement, thank you for joining us. We really appreciate the fact that you're taking a first step in improving your health. Thanks, LaToya.
Thank you. Now that you all have been properly welcomed, let's jump into the discussion. I want to first introduce our presenters. I am joined today by Dr. Bevan Bean Mayberry, who is a staff physician and court investigator at the VA Greater Los Angeles HSR&D Center for the Study of Healthcare Innovation, Implementation, and Policy. She is also a clinical professor of medicine at UCLA School of Medicine and the GLA site lead for the Women's Health Practice-Based Research Network, a former VA Women's Health Fellow, Career Development Awardee, and current primary care provider who focuses on primary care quality and prevention by gender, women's health clinic setting, or provider type. Her current interests include preventative care, cardiovascular risk reduction among women veterans, and motivating women to take one step toward better health. She is the spouse of an OIF veteran and a mother of a Marine. Also joining us is Dr. Elizabeth Lay, who received her medical degree from Yale School of Medicine and completed internal medicine residency training at Yale New Haven Hospital and cardiology fellowship training at the University of Virginia. She is currently a staff cardiologist at the VA Portland Healthcare System She is also their Echo Lab Director and an Associate Professor of Medicine at Oregon Health and Science University. She is a fellow of the American Heart Association and serves on the American College of Cardiology, Federal Cardiology Leadership Council. Her clinical interests include general cardiology and heart disease in women. So as you can tell, we are being joined by experts in the field that truly have some great information to share for us. Thank you both for sharing your time and expertise with us today. Dr. Lay, where do you think we should begin this conversation?
Well, thank you very much, Dr. Harris, for inviting me to participate in the town hall today. I think we should start by providing our attendees with some facts about women and cardiovascular disease. So what is important for you to know? Well, we know that cardiovascular disease is the leading cause of death in women. It still is, but less than half of the women are aware of this. We know that among females aged 20 and older, nearly 45% have some form of cardiovascular disease. For us women, we experience unique life stages such as pregnancy and menopause, and that's the time when our risk can increase. So we need to be aware of that. As far as cardiovascular disease and stroke, 1 in 5 women will have a stroke, and women are more likely to have a stroke than men. And then finally, in terms of women veterans, unfortunately, the mortality rates have not improved for women veterans compared to non-veterans over the past 2 decades, despite all of our improvements in therapy and understanding of the disease. And then finally, women veterans experience more anxiety, more depression, post-traumatic stress disorder, chronic stress, and housing instability than non-veteran women. And these factors increase our risk of developing cardiovascular disease.
Thank you, Dr. Lay. So what do you mean when we say heart disease? And I know you touched a little bit on the prevalence of it among women, but just how big of an impact is it?
It is quite big. So when we say heart disease, in general, we mean coronary artery disease. And that is when the blood vessels of the heart have cholesterol buildup. And when it becomes severe, women are prone to having a heart attack. Okay. However, but if you look at the term broadly, it can also include the muscle. So heart failure, there can be a problem with the muscle and the heart pumping normally. And then finally, heart disease in the broadest term can also include valvular heart disease, where there's a problem with one of the 4 valves. So it can be too thick and calcified, so it doesn't open as well or it doesn't close as well. But I think for this town hall, we will be concentrating on coronary artery disease or coronary heart disease.
Now, you mentioned the prevalence for women. So if I get a group of my girlfriends together and we go out to dinner, you mean 1 in 5 of us is at risk?
Yes, so 1 in 5, but if you include the risk factors for heart disease, up to 45% of us will have some form of cardiovascular disease, right? And that includes high blood pressure.
It's good to know. Now, is there anything different that women veterans should know about heart disease?
For veterans, I think we should also be mindful of the stress. So the mental health disorders that the women veterans tend to have more than the non-veteran women. And we tend to ignore that because the chronic stress can exacerbate or make worse all the risk factors for the heart disease.
Okay. Dr. B. Mayberry, anything to add to that?
I completely agree with Dr. Lee. Sometimes what we'll describe for risk factors is we'll talk about traditional risk factors and then non-traditional risk factors in both primary care and cardiology. And so for those traditional risk factors, we're talking about the ones that AHA emphasizes all the time. Some of the people might have seen the image of Life's Essential 8, And in that wheel, those are our things like smoking, blood pressure, cholesterol, glucose, and then sedentary lifestyle, no physical activity, weight gain, poor diet. And the eighth one that has been added is now sleep disorders. And so all of those things contribute to our risk for heart disease. And all of those things are places for us to be screened and places where we can begin to pick one thing to improve.
Now, the movies and television typically show men clutching their chest in pain when they experience a heart attack. Is that truly an accurate depiction for women as well? What symptoms should a woman be worried about?
So for women, most of the time, women will present with chest pain when they have a heart attack, but that is not always the case. So we need to remember that women can present with just shortness of breath. They can come in complaining of just being tired, not being able to do their usual household activities, daily chores, or they can even come in saying, I have back pain, I just have arm pain. Um, I don't know what's exactly is wrong, but I know something's not right. And those are the symptoms that the veteran should bring up to their providers.
We know that heart attack can be very scary to think about. So in a scenario where you have a friend who shares that perhaps she's feeling her arm is unusually heavy or perhaps it's numb, and she's wondering if whether she should make an appointment with her primary care provider or if this is something that's more emergent and she should get to the ER by calling 911, what would your advice be in that case?
That's a great question, Dr. Harris, because sometimes what we do for others is not the same as what we do for ourselves. So, in that particular setting, we actually want the woman to not waste time and to be evaluated as soon as possible. So, we want her to call 911. We do not want her to get in her car and drive and be in traffic. We want her to call 911 so that someone can get to her home or her location as soon as possible.
All right. Now, you and I both know that most often women are the caretakers in the home. We are generally taking care of so many people all the time. And that sometimes means that we can put our own needs on the back burner, taking care of everyone else. How can we empower women to really put their health first, prioritize themselves, and go see their doctors?
That is a great comment, Dr. Harris. I see that in my patients a lot. So we have to remember that we cannot pour from an empty cup. So if we do not feel well, we will not have the physical strength or the mental stamina to be able to take care of our families. So we have to put ourselves first. Um, One way to do that would be to make sure you schedule the appointments for yourself and make sure that you have a list of concerns you would like to speak to your provider and just put it on the calendar. Often, if you write it down, it'll be easier to follow through. And remember that if you need to make a commitment, you need to make a goal to accomplish. And if you can do that, to start with one goal at a time, and then as you accomplish it, that would give you the motivation to go to the next goal. It doesn't all have to be done all at once.
Excellent advice. I know that what you said earlier really resonates with me. You cannot pour from an empty cup. And if we want to be the best mom, the best wife, the best partner, you have to be able to take care of yourself first. So that's definitely great advice. So we know now that heart disease is preventable. There are things that we can do. What practical steps in terms of risk reduction can women take today to take charge of their health?
I think that the first step is to make the appointment, to get it on the calendar, and then to write down your questions. So it'll be hard for you to remember to ask all the questions in such a short time that you have with your provider. So it's okay to come in with a list of questions, a list of things that are important to you, and discuss that with your provider. And often, if you wait until the night before the appointment, you're going to be in a rush and you won't remember. So, what I advise my patients to do is if you have a question, write it down in the diary and write it, and you have it as you go along. So, by the time you have your follow up appointment, let's say in 2 months, you have a list of concerns that can be discussed.
Absolutely. I'd add to that, if you're going to a new provider, bring the history you've learned so far. Whatever conditions you've managed, even if they improved and you're not being treated anymore for them, you still need to bring those up at that initial visit so that that new provider has that information. Whether it's your primary care provider, whether it's your cardiologist, you want to let them know if you've had any of those risk factors we've talked about. You want to let them know if there's any family history. And you also want to let them know if during certain stages of your life, conditions changed. So, did you have specific conditions during your pregnancy that would put you at risk? Your providers need to know that because women have increased risk of heart disease when they've had a condition during their pregnancy. All women. So if you've had hypertension during your pregnancy, if you've had diabetes during your pregnancy, if you had an issue that resulted in preterm labor, then you need to make sure all of your providers know about that, even if you're fine now.
Excellent, excellent advice. Now, unfortunately, we know that the research tells us that women are sometimes undertreated or misdiagnosed. Maybe there are delays in care. You've spoken a little bit about what to make sure you have at that appointment with your provider, but are there any other tips or advice you can give us on making sure that women are seen and heard when it comes to their health, not just dismissed as perhaps having anxiety or just being too worked up? What can we do or tell the women that are listening, or those that are partners, to let them know what to do so they can be heard and seen?
I would say you need to be your best. You're your best advocate. Okay. So sometimes you may think that it's not relevant and you may not know, but go ahead and share it with your provider. For example, shortness of breath. You may hear that, well, if I'm not having chest pain, it may not be a heart attack, but I am short of breath. And let your provider help you determine if the shortness of breath is due to your heart or something else. Okay. So again, if you feel that something is just not right, you're not feeling well, and that it's a change from a month ago, 6 months ago, just share it with your provider, and the two of you together can figure out what's going on.
So really being a partner with your provider and being as transparent as possible is very important.
Yes, yes. The more the provider knows, the more we can help the patient.
If we present to the ER with symptoms that we don't feel are being taken seriously, what do you suggest a person does in that situation?
I actually have recommended people go back to the ER or go to a different ER, but to not discount what's happening in their body so that they get an evaluation and get to an answer, or if not get to an answer, get to ruling out the things that would be most detrimental for them.
Okay. Now, Dr. B. Mayberry, I heard you mention a lot of ways that we can work to reduce and control our risk. We know that exercise and diet are key. But what if that provider says to us, you know, it's time for us to move toward taking medications, and they're prescribing medicines. But what if I don't like taking those medications, or what if those meds are too expensive? What would be your advice to me in that situation? And that's for Dr. Lay as well as Dr. B. Mayberry. What would your guidance be?
That's a great question, Dr. Harris, because that does come up. I imagine it comes up for both Dr. Lay and myself in clinic. And you should let your provider know kind of where your attitudes or feelings are, and what may be the reason behind it. And if there's a prior experience that's guiding that, so that then you can at least be on the same page and make a plan together. Lifestyle changes with regard to our physical activity and our diet choices are things we're supposed to do throughout our whole life. So those are places where we're all supposed to start with the treatment regimen for almost every single risk factor. And so that is always a good place to start and make a simple goal. However, you must come back to the goal and evaluate it, even if it's just 1 month later, to see how you did and why it worked well or didn't work well. Failure is not a problem. Failure is a time to identify what the difficulties were or the barriers were and reset the goal. And often that requires quite a bit of communication with the provider to figure out what will work. But there are ways to get additional support in the VA and outside to help move the lifestyle goals forward. And then to say, if this is not working in a certain amount of time or in a repeated modification, then maybe we need to start meds. And so meds can be started in small doses. Meds don't have to be forever, depending on the condition. And so those are good conversations to have, so that people know what the doctor's thinking and what the patient is thinking.
Okay. I couldn't agree more. Dr. B. Mayberry, I think it's very important for the veteran and the provider to be honest with each other, because I think the outcome will be best if it's a shared decision-making relationship. So please be honest with the provider, and then we can help you work around whatever challenges or barriers. When we prescribe medications for you, usually we give you the most common side effects. But remember, every patient is unique. You are unique. You are important. You have different genetics. So just because we didn't mention it, it doesn't mean you cannot have that particular side effects. So just share that with your provider, and then we can find different medicines, other ways to help treat you so that we can get to the goal that you set.
Okay, excellent. So now, oftentimes, and being February, we know we come out of January making some great goals for our lives to really get us back to where we need to be in terms of health. And there are many of us out there who can say they've been working really, really hard to take the steps necessary. Many of the things that you all have discussed, trying to control their BP, trying to control cholesterol, eating better, working out daily. But sometimes you get to that point where you feel like nothing is changing. There's no progress being made, and you're really starting to get frustrated. What advice do you have for someone that is finding themselves in that situation? They've been putting in a lot of effort, and unfortunately things aren't moving as fast or as far as they'd like.
That's also a great question, Dr. Harris. What you're describing is sometimes what happens when we hit a plateau, or what happens if we feel stuck. Um, and and as I said before, failing is not a bad thing. It's an opportunity to figure out where are my barriers, and what do I need help with, or what do I need to reset. And so start with simple goals, so that what we're trying to do is not just have a specific outcome, but to have a lifestyle that's healthier overall that we can carry with us as we age. And so just because maybe the weight isn't coming down, are you still persisting with the activity? Are you stronger? Is your breathing better? Is your heart rate better? All of those things are important to see as benefits and moving toward the goal. Is your endurance better? So I often tell people, if they've set a goal, or let me step back. Our physical activity recommendations for adults are 150 minutes per week of moderate activity. And that would be walking where it would be hard to carry on a conversation. And so that could be broken down into 30 minutes a day. Some people can't start at the 30. I say start at the 10. If you can't start at the 10, do 2 songs. 2 songs are usually about 3 to 4 minutes. If you can do 2 songs, then you've got one goal you've reached, and then build from there, so that your stuckness is informing you of something you need to slightly do differently, or to reset the goal, so that then you can make progress and build on it.
I like that. Very, very small, measurable steps. Dr. Lay?
So I also want to add that you don't have to do this alone. Okay, so if you have family, if you have friends, walk with a partner. The two of you can be accountable for each other. So I think that would help. And again, I am a big fan of writing things down and having a list. So for example, you can get a calendar and say, I'm going to walk two days a week this week, and 15 minutes, each time, and just check it off. That would give you the satisfaction that you've accomplished a goal. And you can also bring the calendar in for your provider to see. Okay.
I want to join in with what Dr. Lay just said. I love when people do that, because then they're setting a SMART goal. So it's something that's specific, measurable, action oriented, reliable, and time dependent. For this month or for this week, I'm going to do X. And then at the end of that time, you evaluate it. And then you can modify something afterwards or keep it. And that's really important for people, because you want to feel like there are successes you're making, so that you're still motivated to keep going forward. And we all need that. And so, just to emphasize what Dr. Lay described, it also allows us to be accountable with very, very specific items with our buddy, or with our provider, or with ourselves. And the other thing, when you're doing those things, track them on your phone. Some people like check off lists. I still do check off lists. But if you've got a phone, a smartphone, let it do the counting for you. Let it do the time measurements for you. And then just bring that in and show it to us or whomever you're working with.
Okay.
You both mentioned this when you were talking. I'm sorry, Dr. Lay, go ahead. I didn't mean to cut
Oh,
you.
I was going to say, similar to having a partner when you're exercising or trying to accomplish your goal, if you can come to your appointments with a family member or a spouse, a partner, that will help also to reinforce the discussion, because sometimes there's so much information that you may not remember, even if you're given an after visit summary. So then having your partner there to review the discussion can be helpful after the visit.
You read my mind. That's what I was going to ask, whether you all as providers are bothered by patients bringing in a partner or a spouse or friend to listen in on that visit, because I know that sometimes that can be helpful in trying to remember just what the doctor has said and or help be your accountability partner afterwards.
Yeah, no, not at all. I welcome having family members during the visit, because sometimes the family member can provide additional information when the patient minimizes the symptoms.
Excellent. I wanted to circle back on something that Dr. Bean Mayberry said earlier, and I know both of you can probably weigh in on this, but there are certain time periods in a woman's life that can increase her risk. And I thought maybe you could circle back to those life stages that you feel women should make sure that they are taking note of those changes when they come in to speak with their provider.
Absolutely. We do want to know the reproductive history of every woman who comes in. And we use that information to understand um, whether or not there's a risk that's present because of a long reproductive period or a short reproductive period. We also use that information to know if the woman has been pregnant and had any complications, like we mentioned. Adverse pregnancy outcomes are female specific risk factors. And as we mentioned, it could be hypertension, it could be diabetes, it could be preterm labor. I think some of the women in the chat mentioned preeclampsia and HELP syndrome that has occurred during their pregnancy. I just happened to see it pop up. And all of those things are important for your non-OB medical providers to also know, not just the obstetrician gynecologist. And then for women who are transitioning through menopause, sometimes there are a number of risks that developed perimenopause and then postmenopause. The older data from the Women's Health Initiative showed us that when women are about 10 years out from menopause, their cardiovascular risk increase enormously. And that is where we see the increase um, prevalence of coronary heart disease and heart failure and AFib. And so all three of those conditions rise at that later stage in life.
Okay.
But Dr. Lee, please fill in if I've missed anything, just because we refer those patients to you.
Yes, so you're right that when a woman hits the menopausal, perimenopausal period, that's when the risk starts to go up and the prevalence of heart disease starts to go up. But for those women who have early menopause, their risk starts earlier. Okay. In the past, we thought that with menopause, you lose the estrogen. So the easiest fix would be to give back the estrogen. But we've learned that even though the estrogen lowers the cholesterol, it actually did not help with the outcomes of heart disease. So our thinking about hormone replacement therapy has changed. And I think, Dr. B. Mayberry, you have better data, but in general, we try to use as little as possible, but to use enough to alleviate the symptoms of postmenopausal state, and then don't use it for a prolonged period of time, right?
Agreed. So as little as possible for the shortest duration to relieve the symptoms.
Okay.
Right.
Very good things to know. This really and truly has been awesome discussion. You both have shared a great deal of information, and because of that, I think it may be helpful if we recap some of the key takeaways for those that have joined us. Dr. Lay, do you want to review some of the heart attack and stroke warning signs?
Sure. So we want you to be cognizant and aware if you may be having a heart attack or a stroke. So for a heart attack, don't ignore a new development of shortness of breath, Most women will have chest discomfort, and the quality of the chest pain is important to note. Usually it's in the center of the chest. It can last minutes and it can come and go over a few days. Most women describe the chest pain as a pressure or a vice-like squeezing, not the sharp pain. Some women will also have indigestion, nausea, and vomiting with the chest pain. That said, some women may not have chest pain at all, and all they would come in with is noting that they have pain in their arms, in their back, in their jaw, or their stomach. Okay. For the stroke, be aware that you may be having a stroke if you notice facial drooping, weakness in your arms or your legs, if you suddenly have difficulty speaking or confused, not understanding what somebody is saying to you, if you have trouble seeing, if you have dizziness, trouble walking, or a severe headache. Because one of the risk factors for a stroke is having high blood pressure that is not controlled. And when the blood pressure is high, there's no warning signs for you to know. It doesn't hurt to have high blood pressure until it's too late, until you come in with a heart attack or stroke.
And Dr. B. Mayberry, I know you wanted to review some of those risk reductions that we can take.
Yes, thank you. And so this diagram is Life's Essential 8 from American Heart Association, and it happens to really correspond with the VA's healthy living messages that are health promotion, disease prevention teams, and whole health teams use when they're working with veterans to provide coaching for specific lifestyle changes. And so the things we want to remind our veterans uh, to do, and even our VA staff, are to eat well, to make healthy choices. Um, when eating, sometimes this might be just choosing one thing to remove or one thing to add that you know would be beneficial. Be active, so be physically active, and that can start in small steps. And what we're looking for is consistency and building endurance and muscle. And that is because this is slightly off topic, but this is because we want to decrease the risk of falls and increase the risk of mobility lifelong, which is really important for all of us. If you happen to be a smoker, we want you, or take tobacco in any form, we want you to get assistance with quitting smoking. Um, I do tell patients any kind of smoking, whether it's a cigarette, a vape, um, um, marijuana, any type of smoking, inhalations, inhaled substance, I want them to quit because I want their lungs to perform as well as possible along with their heart. Get healthy sleep. So this is about the sleep risk factor being added to risk for cardiac disease. And so what we definitely know is that there are multiple types of sleep disorders. One in particular that we're concerned about is obstructive sleep apnea, which is associated with hypertension, high blood pressure. And so we want people's sleep apnea treated, but we want to also know if they have something different from sleep apnea too, because we want to understand what's there and how it's impacting them. Managing our weight so that we are not gaining as we age, which is very easy for all of us to do. And so that we are combining that with physical activity regimens and healthy choices so that we're stabilizing our weight, or if needed, working to bring down our weight. And let me mention this, just because you're thin does not mean you're not at risk for heart disease. Let me say that again. Just because you are thin does not mean you are not at risk for heart disease. You still need to be physically active and have your risk factors checked. And then, of course, the ones most people have heard about, controlling the cholesterol panel and looking at the different types of cholesterol and reviewing that with your provider. And then also looking at whether or not your blood sugar is uncontrolled or your blood pressure. So one thing to mention here is that we now look for pre-diabetics as well as diabetics. And maybe 10 years ago, we didn't do that. Now we do that so that everyone should know what their A1C is, or hemoglobin A1C, which is the sugar on the red blood cell test. That's essentially what it is. And we work to improve both of those measures if needed. Then we control stress. And this is a big one for women, and this is a big one for veterans. As Dr. Lay mentioned, there are many mental health conditions that may come up for veterans and may come up for women. And so we want to make sure that people have support for those because those impact their cardiovascular risk profile. And we know that there are newer studies that look directly at PTSD as an emerging risk factor for cardiovascular disease and specifically coronary artery disease. And use the VA's whole health program and health promotions programs in order to get the support you need to just pick one area to start and make a change, because that one area improving could have a ripple effect on other things.
Awesome.
I've talked quite a bit. I'll let you guys finish.
It's all great information, very helpful. And just as you mentioned, all veterans who are enrolled in the VA healthcare are eligible for cardiovascular risk assessments, prevention services, and treatment. Let the VA be a part of your support team. And we have listed here many of the programs that your local facility can provide to you. There are a wide variety of services to promote your heart health, including diagnosing and treating heart disease, as well as lifelong risk reduction. So partner with your VA in getting your health under control. We want to thank you again for being here today as an important first step. And if you're wondering what to do next, we want to encourage you to focus on at least one of the following areas. Schedule or keep your doctor's appointment to discuss your cardiovascular risks. Choose one or two healthy lifestyle changes that you can commit to making a change today. And of course, continue to educate yourself on cardiovascular risk factors. Both the VA and the American Heart Association have wonderful resources and tools that are available to assist you. So take the time right now to commit to doing one of those steps as you complete the program today, so that we know that you'll move forward making a full commitment to taking control of your health. We're going to open the session up now to any questions that have come in through the chat. I did see many of those pop up as we were discussing. So if you have others, feel free to type them in the chat box and we are going to field those for our experts. But be mindful that you do not include any of your sensitive information in those questions. And we'll take a few of those now. Heather, do you want to get us started?
I can. So there were a couple things in the chat that talked about sleep apnea, which I know was touched on. One of the questions was, how does sleep apnea play a role in heart disease? And another question around sleep apnea says, is it possible to treat sleep apnea without having to use a CPAP machine or mask? So I was hoping that we could lump those together. Dr. B. Mayberry or Dr. Lay?
So I may have touched on it just a little bit at the end or that last slide. And so we do know obstructive sleep apnea is associated with hypertension, and both need to be controlled. And that's why not treating the sleep apnea is important, because it does increase your cardiovascular risk. The issue about equipment that comes up for many people, they have changed some of the masks and devices that people can use. And so I do ask some of my patients to go back to sleep clinic and see the pulmonary specialist and or the technician that works with them to see if they can have a different style of device or mask that could still improve their apneic episodes without causing them too much discomfort or aggravating their mental health symptoms. Sometimes that is what people tell me. So I would say discuss it with your providers, and if needed, get the consultation to see the sleep medicine specialist again.
Thank you.
I also want to add that when you have sleep apnea, if it's untreated, it can lead to hypertension, as Dr. B. Mayberry commented on. Another thing that happens when you don't use the CPAP or you cannot tolerate it is while you're sleeping, the oxygen level gets low in your body. So when that gets low, you can also have high blood pressure, but in the lungs. So not the kind that we measure, but it goes high in the lungs. And when the pressure is high in the lungs, the right side of your heart has to pump blood through the lungs, and the right heart can start failing. So that is another form of heart disease that can happen when patients have undiagnosed or untreated sleep apnea. Okay.
Thank you,
Thank you.
Dr. Lay.
Another, oh, go ahead. I was just going to say there another question that we saw toward the top of the hour was about the connection between heart disease and PTSD, seeing an increased rate there. Is there a connection?
I don't think there is a direct link, but what happens with PTSD, I think, is there is stress. And sometimes patients do not like to come to the hospital to visits because there's too many people. It's too overwhelming. So they tend not to follow up with their doctor's visit as much. And I know that even though we have telehealth available, when I see a patient in person, it makes a much richer experience. When I see patients in telehealth, uh, I don't get all of the information, I don't think. So patients with PTSD may not want to come to get their blood drawn as often, come to see their providers in person. So I think that can lead to less attention that they pay to their cardiovascular risk. And that can increase their heart disease and the stress too, the mental stress. And that can increase your catecholamine, your adrenaline. And that just makes the heart work harder and lead to blood pressure being high.
I saw a question earlier that asked about recommendations for LDL and HDL ranges for women.
That depends on your risk factors and whether you have a diagnosis of heart disease or not. In general, we use different calculators to estimate your risk. And if you fall into the high risk group, you may need to be treated with medications and not just lifestyle. A rough number to remember is if you have not had a heart attack or have known blockages in your arteries, your LDL, which we commonly call a bad cholesterol, should be less than 100. And if you have had a heart attack or you have diabetes, it generally should be less than 70. Those are the two numbers I keep in mind.
I use the same in primary care. Okay. And if there are any questions, I ask cardiology to give us input. Heather, you're on mute.
Sorry. There's a lot of questions around menopause, perimenopause, hormone replacement therapy, which I think we touched on. Someone also asked if you're at a greater, I think she meant a greater risk if you've had surgical menopause. And then there's also a comment about contraindication around HRT, and debating whether to use that or not. And I think we kind of touched on that, but if there's anything else there that you want to talk about with risk.
I'll make a brief comment, the one about surgical menopause, because some women may need surgical menopause, may have to have their uterus removed in addition to their ovaries bilaterally removed, both sides. And so it really depends on what is the underlying diagnosis for the surgery and on whether they will get hormones right after, because they will go through menopause if their ovaries are removed. They're going to have menopausal symptoms post-op. And so that discussion should occur prior to surgery, first of all, along with whatever the indications for surgery are. And I'm saying it that way because some women may have surgeries because they have a they have a malignancy, a cancer, or a precancerous condition, and they're thinking, let's just take everything out now. Let's not wait. And so you want to know if that's the reason, or and discuss risk, or is it secondary to a condition that's fibroids, uterine fibroids with lots of bleeding and pain. So it's not malignancy oriented, it's benign in that sense. But then you would be most likely a candidate for hormones post-op. And that should be discussed because you're going to be symptomatic post-op. And so you would want the other health risks that you have assessed so that you know what the doctors or your team is planning initially, and then make that part of the conversation of your post-op care, because it may be that the surgeons might be focused on one specific area, but then you need your medical team, primary care, cardiology, endocrine, focused on the other part so that nothing is being forgotten.
Okay.
I hope that answers it.
Okay. And I think the question of whether postmenopausal women should start hormonal therapy, that's an individual shared decision making between you and your provider. As a cardiologist, I don't treat, that's not part of my practice. But in general, what I would say to patients are, if the postmenopausal symptoms are so debilitating, it's affecting your quality of life, then you can start it, but knowing that you shouldn't be on it for a longer period of time. And it depends on the symptoms as well. So if it's, for example, vaginal dryness, then there are creams that can help take care of that symptom, but you're not taking the pill. So it's not systemic in your body that would affect your arteries and the cholesterol. So it's all depend on your symptoms and how it is affecting your quality of life.
I see one other question earlier that says that the person recently found out that they have a genetic heart issue. Does that put them at greater risk for heart disease, or is that a completely separate issue?
That depends on what the genetic problem is. There are many different mutations that affect the heart. Focusing on cholesterol, there is a genetic defect that increases your cholesterol. So for patients with that condition, they I would recommend that they be on a statin medication or a medication that lowers the cholesterol, because we know for that population, if it's untreated, they will have premature or a heart attack, so heart disease at an earlier age. I also see a couple of questions on AFib. Can I answer those, Dr. Harris?
Absolutely.
I think there's a question, can AFib lead to a heart attack? The simple answer is yes. So when you're in AFib, if your heart rate is going very fast, it's stressing the heart muscle, and you can have a small heart attack. And usually we see that when we check your blood tests. The other way around is more concerning. If you don't have atrial fibrillation and you come in with a heart attack and have AFib, that means your heart attack is pretty big to cause atrial fibrillation after having a heart attack.
I do see another one that says, everyone talks about high blood pressure. I have fluctuating blood pressure, and a doctor told me that that meant I was at greater risk for a stroke. Is this true or false?
This can be true because when you have fluctuating blood pressures, depending on how high or how low it is, it's very difficult to treat, because we can give you medicines to lower the blood pressure, but then if it makes your blood pressure go too low, then you're not getting enough blood flow to your brain. But usually it's the high swings that is most concerning. That's when you can have a stroke from a blood clot, or if it's too high, your blood vessels can break in the brain and cause a bleeding type of stroke.
Okay, I think that that takes care of most of the questions that came through. We are at the top of the hour, so we'll make sure that we are respectful of everyone's time. Thank you again for participating in today's virtual town hall. Please be sure to check with your local VA facility on what additional Heart Month activities are taking place. And we want to thank our presenters, Dr. Bean Mayberry and Dr. Lay, for their time and all of the wonderful information that they shared with us today. Thank you all, and happy Heart Month.